So there we go. Recording is in progress. I will quickly say, first of all, welcome to everybody for coming into this breakout room. And I am going to hand it over first to our presenter, Dr. Nikki Edge. Nikki is coming to us from Arkansas, and I'll let her say hello and introduce herself and then share her presentation. And then we'll have time for conversation and questions. So Nikki, to you.
Great. And is it, Joy, are people's cameras have to be off or they can turn them on? That would be great if people felt like they could turn their cameras on and we can see each other and have a nice dialogue.
Oh, yeah, it's always fun to see the backgrounds too, right? Like Tammy's got a background on.
Yeah.
That's nice. So yes, please do.
Great. Well, I'm Nikki Edge. I'm in Arkansas and Little Rock. I'm at the med school here in the Department of Family and Preventive Medicine, where I get to do lots of things related to early childhood mental health and to trauma-informed care. And so I'm just going to be sharing a little bit about what our state is up to with our PDG grant and some things that we've been working on kind of before that. So let me share my screen. And if somebody can give me a sign that that worked. Be great.
Looks good, Nikki.
Great. And now I'm just going to get y'all back on my other screen so I can see your faces. Great. Okay. Well, Arkansas is really committed to embedding trauma-informed practices across our early childhood system. And this is something that we've been really working on for a while. And as part of our PDG grant, this is one of our main strategies. And we've established a trauma-informed care work group to kind of advise and guide us on how we can offer a range of training opportunities targeting early care and education, as well as our other system partners, as well as other supports like technical assistance, consultation, and coaching. And as you'll see from the visual on the slide, our philosophy is really that adopting a trauma-informed approach is a journey. And that trauma-informed programs are built on a foundation of a healthy and stable workforce, strong developmentally appropriate practices, and consistent implementation of social and emotional supports. And that's probably kind of an obvious statement to many of you, but I'll unpack that just slightly by saying that what we know is that children and families that have experienced trauma need positive relationships that last. So reducing staff turnover, reducing overwhelming staff stress that so often drives turnover, we think of as kind of the foundational step in kind of journeying toward trauma-informed care. And building all that on that, we know that just like all children that have experienced trauma need environments that are developmentally appropriate, especially given what we know about ways in which trauma can disrupt typical development. And we need staff that understand potential developmental delays and can understand and support them. Next, we know that all children, of course, need opportunities to strengthen their social and emotional skills. And so when program staff make that mind shift change, that children need to be directly taught social emotional skills, and that often behavior concerns represent an unmet need or a missing skill that can be supported and taught, then we're well on our way toward an environment that is going to help meet the needs of children and families and staff with experiences of trauma. And then finally, we think about building on that foundation. We can learn more about the ways that trauma impacts children. We can think about the particular experiences of individual children and families and become more astute at making the connection between what they've experienced, what needs they have today, and the tools in our toolkit that might be helpful. And so kind of getting savvier in our understanding. And so what we have learned in Arkansas is that we have to be able to meet early care and education providers and whole programs wherever they are on this journey. We can't just jump to the end of it and think that sharing information about trauma will be sufficient to create a trauma-informed program. And so we've been thinking for a number of years in Arkansas about how to do that. How do we think about meeting programs where they are in this journey toward becoming more trauma-informed? And one of our answers to this is kind of a new program that we call Array. This is a regional team-based approach that was designed to organize and implement a continuum of training and supports that would move programs forward in their journey toward trauma-informed care. Specifically, Array is designed to increase coordination across professional development providers in our state so that we're not working in silos. Instead, we're working in regional teams, partnering with early care and education programs, using a strengths and needs assessment process to identify where programs are in their journey, and identifying the training in our continuum that best matches the needs of the program and would move them forward. All our professional development partners are committed to training all early care and education program staff together site-wide, and to offering implementation support, coaching support to increase the likelihood of sustainable change. As you can see, if you squint at the little graphic that we print on giant sheets of paper in Arkansas, you can see that our offerings vary from basic to intermediate to advanced. There are offerings for administrators, and that we've linked them to the teaching pyramid so that we have a common language to talk about areas of focus of the various trainings. So Array has been operational since before the pandemic, but we're expanding statewide with our PDG funds. Now, for programs that are further along in their journey toward trauma-informed care and are really ready for something more intensive, we have a 2-year organizational change model that we call FIRST ECE. That stands for Fostering Informed and Responsive Systems for Trauma. And it's we think of it as the capstone program for a program's journey to trauma-informed care. It is developed to be aligned with the NCTSN framework that you see on your screen. We've adapted that for pre-K and early care and education. So it's a 2-year organizational wide change approach that focuses primarily on the 3 prongs that you see on your screen there. So raising awareness among all staff in a program, strengthening classroom practices through a 5-part training and coaching series, and then looking at other aspects of organizational change, policies, procedures, partnerships, et cetera, through facilitation and support of a change team in the organization. So we've done, I think 5 rounds of pilots of this, evaluating, tweaking, changing, and gathering good data. Now, this is resource intensive, requires a great deal of readiness and stability. Not everybody is ready for this. And so with PDG funds, we're taking elements of this and making them stand alone so that we can broaden our array of offerings. So we're rolling out new basic trauma awareness trainings. I'm sure most of you have similar trainings in your state. We are taking our first ECE training series for teachers, the one you see on the bottom there, and rolling out a 20-hour advanced certificate program for teachers. This focuses on what we call the 5 S's of trauma-informed classroom practice. So we cover safety, supportive relationships, self-regulation, social skills, and self-care for the staff. And then we've lifted out some of our administrator-focused resources and are offering a new administrator training and toolkit that focuses on making changes to policies, procedures, and practices that happen at an administrator level. And then to address the needs of additional stakeholders and other needs in our system, we're doing several things. One is that since 2016, we have had a program called Behavior Health. And that's our state's single point of entry for support related to serious challenging behaviors. And what we've learned through 7 years of experience is that about 60% of the time, those are trauma-related needs. And so we think about that as both expulsion prevention and trauma support. And it's through that program that that sites can be supported with technical assistance or mental health consultation. And we are surging staffing on that for what we're seeing as the needs post-COVID, and doing that with PDG funds. To support parents, we're expanding implementation of an 8-session psychoeducation curriculum for parents who have children birth to 6 that have experienced trauma. That program is called MIGHT, Managing Youth Trauma Effectively. We're leveraging our telehealth mental health program here at UAMS, and they're expanding what they offer and offering some specific supports to our workforce, wellness supports, case management, concrete resources, connection to treatment when it's needed. And then to touch our partners across our system, we're going to be doing a statewide multidisciplinary conference that's designed to raise awareness and build skills for trauma-informed care among any child serving, any program that serves families with young children, basically. So our partners at WIC, SNAP, Child Welfare, et cetera. So that is kind of some of the surge that we are doing in supports with PDG that we hope is going to move the needle here. And I'm going to stop talking now, and I'm excited to know what y'all are doing in this vein, and what lessons y'all have learned that we might learn from. And let me see if I can stop sharing. Can see each other.
Thanks, Nikki. So yeah, are there first, I guess, questions for Nikki about anything that she has been talking about that Arkansas is doing? Any follow-ups or clarifications, or any questions that you have for Nikki?
Hi, Nikki. This is Tammy. Let me cut my camera. Tammy Proctor, of Department of Education. Can you talk a little bit about the 8-hour cycle education training that you do with parents?
Yeah. So that first was developed out of UAMS a number of years ago when our state asked us to develop a curriculum for use in specialized women's treatment programs where moms and babies were in substance abuse treatment together. And we did that, and that was really successful. And so they asked us to create like a generic version of that for any audience that is providing care for children that have experienced trauma. And so it provides basic education about what trauma is, impacts of trauma, how we create kind of trauma-informed homes, I think, like how do we create consistency and predictability? We call it routines that reassure. And how do we support, kind of children's emotional development? How do we know when children need more support? How do we manage challenging behaviors in ways that won't re-traumatize? So kind of some basics of good caregiving, but through that trauma lens. And so we've been kind of using that. We have a version that's specific to foster parents, but also a general version for the general public as well.
Okay, thank you.
Nikki, did you share how that's delivered, or did I miss that? Because I got a call from my boss in the middle, but how is that delivered to you?
We have had a lot of success in delivering that in two ways. One is in programs where parents are naturally are, like, in our substance abuse treatment programs, for example. But also lots of success with delivering that in virtual groups, combining parents from all across the state. And so we are going to do a little bit of both in this round. But the way that the curriculum was designed is it's designed to be able to be delivered by a wide range of facilitators. So it can be delivered by parenting educators. It can be delivered by substance abuse treatment counselors, by mental health professionals, by kind of anyone with good group facilitation skills and who's willing to kind of go through the train the trainer process, because we're not it's not treatment, it's not processing trauma, it's education, and it's very kind of well scripted for folks who want to just kind of pick it up and go with it.
Thanks. Are there other questions?
I have one. Hey everybody. Hi Nikki. Nice to see everyone.
Yeah.
I'm curious about outcomes data, particularly for the workforce folks. How do you know they're getting the services? Maybe they get the recommendations for trauma mitigation, but do they have the necessary supports, therapies, interventions available to them within their benefits plans, their employer resources and whatnot? How do you know?
Good question. So with all the trainings and technical assistance and consultation and things that we provide, we do have strong evaluation built in. And so we're gathering data from the teachers, we're observing in classrooms, doing structured observations. So all those are pretty well evaluated. The workforce piece is leveraging our tele mental health program to provide supports to the workforce. That's brand new. that did not exist before. So we're building out, we're actually had a meeting today figuring out how are we going to evaluate that. And so trying to figure out that, because what anyone experiences through that may be very different. They may decide to take a wellness course. They may choose to connect to a case manager. They might choose to get referred to treatment. And so I don't know. And if anybody has done something similar, we're still figuring that out. I'd love input. It's easier to evaluate a course that they attend, for example, but how they benefit from other supports will be a little trickier. And especially because some of that will be confidential.
Right. And with the kids, there's a mandate to serve children with identified needs through some avenue, whether it's public or private, but there's not that mandate for adults. So how are we getting the supports they need, and then secondarily are prepared to support the children in their care?
Yeah.
Good work, though. Thank you for sharing your model.
Thank you.
That gives us a couple of additional thoughts. Of any thoughts about that? Any other additional questions about the interesting angles that Arkansas is taking to their trauma-informed care? I have other questions. So, no escape. So what's going on in your states? Are there similar initiatives, different types of initiatives? What brought you to this session? Is there anything from your state's perspective that you would like to share that's going on in your area? Oh, I agree. So I really appreciated the various programs for multiple entry points. That's I think that is super interesting. Is there anything further that we could share about the multiple entry points?
Me or others, or
Anybody?
we are really trying to take advantage of multiple entry points, and we've been having a lot of conversations about that in our state. One that I'll highlight is that, so I mentioned briefly that we have a very robust expulsion prevention program that's been in operation for about 7 years now. And so we're trying to leverage this opportunity with the PDG to try to find some new ways to support some of our early care and education programs that seem to need that technical assistance and mental health consultation support more frequently than others, which is, telling us that something is stressed and strained in their system. Something's not, able to generalize across. Maybe they're, we'd like to build their more foundational skills. And so we're trying to consider that like an entry point, not just to try to prevent the expulsion or improve the outcomes of this particular teacher, child, and and family, but say to these administrators, what else are you interested in? Would you be interested in partnering with Array, engaging in a strengths and needs assessment so we could help you think about where you want to move as a program, and kind of considering all of these as potential entry points to a longer engagement with a program, and kind of helping a whole program move forward. We have lots of wonderful trainings in Arkansas, but when one teacher grabs this and one teacher grabs this and one teacher grabs this, it's not helping a whole program grab a hold of something and move forward together and support each other. And so that's what we're trying to really kind of try to increase.
So you've mentioned a lot that PDG is taking some pieces of this, and definitely I think, and I see a question. So let me divert from my question. Let's look at the question in the chat. How do you help providers and teachers understand this isn't just another training when they have gone through the teaching pyramid already? There's fantastic overlap, but I can hear providers starting there. I think that's a really great question. So why don't I toss that to you, Nikki, to answer?
Yeah. Well, I think that oftentimes we're getting connected with programs who are searching for something. There's a lot of, I don't know how it is in your state, but in Arkansas, a lot of our programs have some staff that's pretty stressed, pretty strained. And they're seeing more challenging behavior than they have in prior years. Kind of the whole system is a little bit stressed. And so, when we're able to go in and really look at strengths and really look at needs and hear them and kind of pinpoint the areas that they're saying they want to grow and move, and saying that we can find a training that matches that thing that we both identified, that's your desire. We have something that matches. And then I think that helps with the sell of it. But yeah. I think that if we can sell 80% of a program, then there may still be that, a teacher or two that's skeptical, but hopefully as a group they can carry forward.
Kristen, I see you unmuted. Did you have something else?
I did. Did someone else? No. Related. Speaking of the sell, how, if you said this already, I apologize, but maybe it bears repeating. How do you get the word out? Who do you get the word out to? What are the channels for participating?
So it depends on the thing. So I talked about a number of different supports, and the way we get the word out differs for all of them. So for example, our expulsion prevention program, we message heavy to our funded providers, so state pre-K and our voucher accepting providers, because they're actually under a policy that they need to seek help. And so they're getting information about that everywhere in their voucher participant agreement, in trainings, in mail outs, in every kind of way, because those are supports that we want to be widely used. For other programs that are smaller and more targeted, we have a much more narrow approach. For example, I talked about our more intensive organizational change model for trauma-informed care. Well, we're real quiet about that because that's intensive, and we don't have the staffing or the bandwidth to spread that everywhere. So we're looking within our array continuum for programs that get referred, that really meet some specific criteria. And then for, I talked about our array continuum, and all of our professional development partners, our childcare licensing staff, our state pre-K, state team members, our childcare aware members, all come to those regional hub meetings, and everybody can kind of bring an early care and education partner to say, hey, I wonder if you'd be interested in a strengths and needs assessment that would help you target how to move your whole program, train your whole program together and move it forward. So we're using really all our colleagues working together in a region. We meet together every 2 weeks in regional hubs.
Thanks. That's helpful, particularly mentioning the pre-K and subsidy receiving participating provider. Yeah. That's a large swath.
Yeah, I think it's like 3/4 of our providers in Arkansas.
That's great. Any information on home-based versus center-based participation?
In most of the things that I have mentioned, we have much more robust center-based participation. We've had kind of a shrinking number of home-based providers in our state, and we have a new family childcare network that's really trying to work on that. And so we're excited to be kind of partnering with them to try to make sure there's not folks that we're missing that we should be partnering with.
So I think one of the things that I was going to ask was that you had mentioned that the role that PDGB-5 funds have played in sort of like entering in and helping to push some work. Are others utilizing multiple funding sources or doing some blending or braiding to help support? I'm just curious, in addition to say what PDGB-5 might be helping to push forward or expand during the period of the grant, we're always concerned about, okay, that's great, we've got some grant funding to kind of push this forward, but what are some sustainable ways that we can keep this going? So I don't know if you have thoughts about that from Arkansas's standpoint, Nikki. I can say when I was project director for Michigan's PDG grant, we thought a lot about, we just want to skill up people and spread trainings broadly or spread skill building broadly so that we can sort of saturate the ground, so to speak. And then once the grant is gone, we don't feel like this big drop off, that hopefully we've kind of skilled people up and can keep it going. But are there other funding approaches that others on the call here are taking? Or Nikki, can you talk a little bit about that too?
I'll just quickly comment to say that we're blending lots of funding sources because some of this is expanding, you know, existing things or surging existing things. So most of the things that I talked about are blended funded across quality improvement dollars that rely in the CCDF grant, state pre-K dollars that are targeted at training and technical assistance, PDG, and then I was feeling like I was missing something, but historically these same services have been supported with things like Project Launch, or even some disaster relief dollars that can be trauma focused. And so we really do try to blend and braid. And if something is going to be time limited, it's so that we can do like kind of a proof of concept, get some good evaluation results, and hopefully position ourselves to be able to seek funding, you know, to continue it.
Does the university put any funding toward this, or is this really a project that is outside funded that you just are able to participate in because of your expertise?
There are some infrastructure pieces that the university supports. For example, when I talked about the telehealth program, the mental health telehealth program, there are a lot of university resources that support that infrastructure, but these grant dollars allow that workforce to do some targeted wellness supports. And so couldn't happen without the funds.
Okay. Good to know. Does anybody have any questions about the telehealth piece? Because that one for me is something that I've been super interested. So I am Arkansas's PDGTA specialist, and I've been really interested to hear about that portion of the work. So I'm just curious if any of our participants are interested in a little more information about that telehealth model.
Definitely interested, particularly in, I guess, the logistics, setting it up, you know, satisfying HIPAA requirements.
Yeah.
What you want to share about, you know, I don't know, what you've learned.
Yeah. So the telehealth program that we're kind of leveraging for this was a program that our med school, our public health program put together in the context of the pandemic, offering mental health services via telehealth. So that whole infrastructure was there and set, all HIPAA compliant, et cetera, et cetera. And that's not what these dollars are funding. So what these dollars are funding is to say that we have this telehealth infrastructure, we have these mental health professionals that are used to working remotely. Let's see if we can use some of their time to function more like an EAP to support the early care and education workforce. So doing training on things like mindfulness, communication, general mental health awareness and concerns, building your bounce, resilience kinds of things. And then they have a case manager that can, when there are needs for more, the case manager can work with any member of this workforce to connect them to either the telehealth mental health services available through Air Connect Now and work through any issues that they might have with insurance or payment, or connect them to treatment, mental health treatment or supports in their home community. They might prefer in-person supports. And so we're not directly providing mental health treatment services with these funds. There's an infrastructure and an approach to do that, but we are supporting connections. You know, a lot of people, you know, can be hard in rural Arkansas to find mental health care in your own community if that's where you want it. And so having a case manager that can kind of facilitate that is what we hope will be helpful. But we're just this is the newest part of our work. We are just developing and rolling this out. And so if anybody's got some lessons learned for us, we'd be really welcome the input.
Oh, so any thoughts from our audience about that? Because I think a lot of the time when we're thinking of mental health supports, and of course this is a session on infant early childhood mental health, but at the same time it is building the capacity of our providers, and we know that our providers need those sorts of mindfulness, wellness, those EAP supports, as our chat is
Yes.
pointing out.
Yes.
So,
and our most recent workforce survey showed that it was something like a third of our providers screened positive for depression. And so, you know, they are stressed and food insecure and in some cases distressed. And yeah, we can't have well classes until we have well caregivers.
Right.
So
yeah, and often just speaking of being in the workforce area, that I seem to be focusing a lot of my time on workforce and early childhood workforce. While we are looking at attracting new people in, keeping people in the workforce is just as important. And so if you're stressed out, you're going to be more likely to leave the workforce than stay. And so thinking about some of these things, sadly not surprising, and they're expected to smile.
Right. And yeah.
Totally agree. And so anything that we can think of or ways that we can help support that, I think are great. And this telehealth model is, I think a lot of people are going to be really interested in hearing sort of what you find from it as you continue to implement.
So are we. And as I mentioned earlier, we've got to figure out how we're going to evaluate it and learn from it, but we will.
Yeah. Any thoughts about, like, as you kind of think about this, how would you evaluate this? I'm a more qualitative researcher, so I'm like, provider stories are always very effective for me. And they're great. You know, that depth of information is always great. But any other thoughts from our participants? Because I know you all have got great things going on in your states. You guys have any thinking about what would be an interesting way to evaluate the success of this? Oh, another good point from Pilar: providers themselves have experienced trauma or have to support family members in crisis at home or in their countries where they came from. So very good point. So we're getting close on time. We've only got a few more minutes. I can throw out another one of our already prepared questions, but really thinking about, I think if anybody has thoughts about evaluation, I always like to do a little like dream about what might be some good evaluation approaches, but are there other questions, topics, things that you would ask to learn from other states or learn from federal staff or from the PDGTA Center?
I can share. I'm from North Carolina, and I lead a project called Infant Toddler Trauma-Informed Care Project, so the ITI Care Project. And we are working with the existing coaching infrastructure in North Carolina, so supporting folks who already have the relationships and are in the centers in being more trauma informed and being more using the principles of infant and early childhood mental health. So none of them are consultants because we don't have that in North Carolina, but we are supporting them around being more therapeutic in all of their interactions and really prioritizing relationships. And we are a research project. So we use lots of teacher surveys around stress and resilience, and director also, pre and post, and the class and DECA. So we're trying to look at it at multiple levels. We've had some pretty significant findings with both the DECA and class on the work, with only about a 5 to 6 month coaching intervention. Very little training. We're really emphasizing we're a coach the coach model, not a train the trainer model, because you can't get teachers in direct. And we're working with infant toddler teachers, so there's no getting out of the classroom to do training. So we are going to them instead of asking them to come to us.
I love that. Is there any place, is there a report or anything where I could look to read more about that?
Google ITI Care Project and you'll see what we have on the website. And we just have been analyzing our data and we'll be posting it there soon.
That's awesome.
Yeah, I'd love to work together.
Other
Well, I would
thoughts?
just like to say, I think I didn't hear how you ensured that you're being culturally responsive and promoting equity in the work. Can you talk a little bit about that?
Yeah. So my brain first goes to our expulsion prevention program in that, and because we all know disparities in discipline, and that's something we looked at really closely there. Done a lot of workforce work with our workforce, the helping professionals that go in, and have been able to look at a lot of data on that, and are really pleased to say that we did not have some of the disparities in expulsion outcomes for when kids are referred into that system that we see, you know, in the national research. What we do still see, though, are that our children in foster care are still more likely to be expelled than other children. And that really kind of led us to some of these paths that we've been talking about today, is that was one of the key inequities that kind of remained for us. And so, you know, and then of course, inherent in trauma-informed care models are, you know, are those culturally responsive approaches. And certainly that's